I'll tell you, it's interesting. Again, as an owner, medicine is probably the only business in the world where your reimbursement keeps decreasing every year. I haven't heard Medicare ever say, we're going to give you more money this year. But costs keep going up, staffing costs, everything keeps going up. So it's just difficult to navigate sometimes. That's why I think small practices are dead. If you look at the statistics right now, it's either you're a hospital employee or you're a big VC firm. And that's why we are in the process of now forming a big group. We're getting 18 practices together, and I really believe in doctors for doctors. And I believe you want to do something where we kind of recreate private practice, but on a big scale. So every doctor practices and does what they love doing. Every doctor comes in, he owns his business, he takes good care of patients, but he doesn't have to do the things that they hate doing.
Thank you, Dr. Bakshi, for being with us today.
My pleasure.
Dr. Bakshi is a triple board certified pain management specialist with over 25 years of experience, serving as CEO and co-owner of PRC Associates and Alliance Specialty Surgical Center, which together operates 7 pain centers and a state-of-the-art surgical facility across Central Florida. Fellowship trained at Johns Hopkins, he specializes in minimally invasive therapies like spinal cord stimulation for chronic neck and back pain. He has co-authored pain management textbooks and national opioid guidelines, earning recognition as a Castle Connolly top doctor. His leadership and global teaching include several courses in Mumbai and Cairo, and all have advanced innovative care models for chronic pain. So this is quite an illustrious background. Thank you for spending some time with us today.
Thank you. My pleasure.
All right. So you've been a Castle Connolly top doctor every year since 2012. What's the one game-changing habit that you practice daily?
I would say, it sounds cliche, but I think I just treat every patient like they're very, very special. I think a lot of doctors forget why we went into medicine in the first place was to take care of patients. And secondly, I think if you've been a patient before, you realize that what's routine for you as a doctor is not for the patient. They come in, they're scared, they're nervous. And if you just walk in and out, say, okay, we're doing this and walk out. So I think the patient experience is very important. And I think I pride myself on, being very compassionate with my patients.
You've done a lot of different things. You have your own businesses, you've grown your practices. You hear so much about doctor burnout, and, often people leave the profession. You've sort of done the opposite of that, where you've done everything you can to grow your practice and business and all of that. What do you think you are doing that others are not? What do you think that you have kind of figured out?
I think taking out the monotony of just doing one thing every day. I like to do different things, whether it's going to conferences. You go to conference, you always get energized. Starting my business, I sold my business to a big pain management practice. And right now I'm in the process of setting up a multi-state, multi-provider business, a pain management practice. So I think doing different things kind of keep you excited. It's a lot of stress as well.
Yeah.
And I can tell you the easiest day of my week is when I'm seeing patients, because you're so used to it. Or it's routine. When you're not seeing patients, there's some fire every day that you're burning out. So it's exciting and stressful at the same time, but good stress usually if you enjoy it.
Yeah. I want to hear more about that. I want to hear maybe a story or two when you go from maybe switching hats, right? You start as a provider, you say it's comfortable, you know it well, it's less stressful, familiar, and putting on a different hat, right? Being more of an owner, then moving into management, et cetera. Like, tell us a story about that transition.
It's a very difficult transition, I'll tell you that. And being a doctor, I can say that most of us doctors we may be good at what we do, but we've never been taught anything about finance. And realistically, it's a business, right? So you have to make sure that you're profitable. And a lot of doctors just don't understand the basics of billing, coding, marketing, finance, budgeting. And they hate it, right? Because they just don't have that expertise. So I decided to do an MBA in healthcare. I didn't do an MBA in anything else because that's what I want to do. And I think it helps me every day. It just helps me kind of navigate the business better.
Going from owning your own practice to then becoming more on the business side of things, you start there. You've probably made some mistakes when you make that transition, right? You mentioned it was a very hard transition.
I've never made a mistake. No, I think I've made a lot of mistakes, and I think you make mistakes because you really don't know. There's no rule book, right?
Yeah.
If I'm doing a procedure, I've been taught in residency and I've learned under different people, so I know how to do it, and I just get better over time, right?
Yeah.
Complications happen there too.
Yep.
But when you're managing stuff, no one teaches you how to deal with employees, what to do with, hiring, firing, a lot of things that you just are not good at. So, you make mistakes, but, like they say, analysis paralysis. If you keep worrying about making mistakes, you're never going to do anything, right? So you got to do your best and hope for the best.
And, retention is a huge part of that. You have a lot of people working for you at this point as you continuously grow. What are the keys to keeping the folks around you super energized?
I think for me, the main thing is, and this is one of the big parts about being, an owner versus being a provider. As a provider, I always kept patients first. And now I think the next thing after patients is your employees. You just have to keep them happy. And it shows from the moment the patient walks in the door.
Yeah.
Your front desk, your MAs, by the time they reach the doctor, they've already made their mind up that this is a good practice or a bad practice, right? To answer how you keep them motivated is really, obviously, bonuses and money is always important. But the most important thing really is giving them the credit when it's due.
Yeah.
Studies have shown that employees care a lot more about being respected than about getting a pay raise. Don't get me wrong. Everyone wants the pay raise and everyone, they expect that. But just treating them nicely, a lot of doctors have no interaction with, and I'm surprised, including a few colleagues of mine who have no relationship with the MAs who they work with every day. They don't know they're married, they don't have their kids. It's just, you have to be friendly. And I tell my employees all the time, I tell my kids all the time, if you're not happy at work, change your job. Because if you're not happy at work, we spend more time at work than we spend with our kids, right? You could leave the office unhappy, you go home unhappy, and it's just so you got to love what you do. That's the most important thing.
Yeah. Well, and ultimately it boils down to, if you're not your best self at work, you're not your best self at home, but also your patients aren't getting this high quality of care, right? If you're not the best version of yourself, you're rendering care on a regular daily basis, how does that affect your patient outcomes?
Yeah, absolutely. It, like I said, it shows whether you as a doctor are unhappy or the employees are unhappy. It just shows to the patients, and they want, you got to put your best foot forward because they're relying on you, right? No one comes to you electively. It's not like saying, I want to go get a coffee, right? They're going to the doctor because there's a problem. So, you got to treat them well, and you got to, whatever your problems are, from that perspective, you got to put on a smile and, be nice with them. So
you've treated both in New York and Florida, so different parts of the country. Is there a different practice style or approach rendering medicine for chronic care and pain specific patients here regionally from the Northeast to the Southeast?
One thing I'll say is that there's a lot more phobia in Florida about opiates. Okay, rightfully so, because that's where all the opiate crisis was, and if you read about the opiate train, and so. I'll give you an example. We have one of the offices we were opening in a town. They didn't allow us to open the pain management practice. They said, not on the main street. You have to be in a medically designated area. And I'm like, you've got all kinds of establishments that should not be on the main road, right?
Of course.
That's okay. But you don't, so that stigma is so big about pain management. And people don't understand that pain management is not walk in, take your opiates and go home. Right? Pain management is a huge, big field. So I think that's a big difference. I mean, opiate crisis is in New York also, people, but the rules are different. Like New York, your mid-levels can see patients, prescribe opiates. Here in Florida, they're very, very strict. And to some extent, it's right. But also, times have changed. This is not that old time of, So I think that's a big difference. And plus, I would say as far as big healthcare systems are concerned, in New York, because you've got, the Cornells and Mount Sinai's and these big institutions, you get patients coming in from all over, right? Including all over the world, literally. But even there, like patients from all over the country. Whereas here, there are so many, there are like 2 or 3 major, chains, at least where we are in Orlando. But they're spread out like different hospitals. So care is very regional. You're just seeing patients from, 5 minutes away. No one's traveling from anywhere far to come to see.
It's so interesting because this opioid epidemic happened. It probably, was impacted you and your practices in one way or another, just because everyone is talking about it.
Absolutely.
But the thing is that while that happened and that was the sort of moment in time, pain is pain. Patients are still in pain. They still need to be treated. There is now this massive stigma on treating those patients effectively. How did you navigate during that time? I mean, it was so stigmatized prescribing opioids, yet there are patients that should be prescribed opioids, right? How did you navigate during that time?
Well, the problem is that the pendulum swung too far this way and now it swung too far the other way, right? When I started my pain management practice, that's when pain management as a field was just starting off, 93, 94. The whole teaching was opiates are not bad. If you can give it for patients with cancer, why can't you give it to patients who don't have cancer? Do I have to have cancer to get pain medications? Valid argument. The problem is it went too far. Primary care physicians were prescribing it. And, there was just, the whole Purdue problem. It just was too much opiates. So today what happens is when I see patients, first of all, our tools have become much better now. We have the PDMP, so we can see if a patient is doctor shopping, right? In the past, we didn't know. They would come and get 120 medication pills from me, and next day they're going to my colleague right down the street. We never knew that. Now we know that. Secondly, we do urine tests, on patients on opiates, so we can see if they don't have the medicine in the urine, that means they're selling it or not using it, or if they have other stuff that illicit substances, then you say they're not the right candidates. So those tools have made us much smarter because previously you're trying to do it. But in my mind, there are 3 kinds of patients who come to you for opiates. Okay, one who genuinely need it, and I prescribe it for them. The second are patients who, for no fault of theirs, are on huge doses because of doctors. We created this, right? We gave patients a lot of medications because we felt it was the right thing to do. That was the teaching. So these patients have come down the years with those high doses of medications, and that's the problem. So those patients, I feel it's not their fault again. So what I try to tell them is, listen, the world has changed. Now we know these medications and these doses are not good for you. So what we do is we either try and bring the medications down, or we tell them there's a procedure called an intrathecal pump, where you put a pump in. So instead of giving 100 milligrams of morphine by mouth, you need to give them 1 milligram of morphine through the pump. So that's something that, those are the options we give them, but we don't just continue on that. And I think the third kind of patient is the patients who are the addicts, right? Those are the patients you don't want to give and you want, but again, you have to be compassionate. You have to try and tell them that this is not, try and get them into rehab, do something else. And again, my daughter's a psychiatrist. Addiction is not something that someone does voluntarily, right? It's a mental disease and they're struggling with it. So, so the answer is not giving them the opiates, but you got to try and talk to them. 8 out of 10 patients are not going to listen to you and storm out of the door. I mean, that's the reality. But at least as a doctor, you want to try and explain to them that this is, things that you can do. So,
Right.
Well, on that note, it's interesting because, like you said, that third category, right? The addicts, or even the second and third category, I should say. Usually, it's the minority providers, right, that ruin it for the rest of people trying to do it the right way.
absolutely.
Right. And so, like, when you look at this problem and you're in the thick of it during the epidemic and now, like, what is your opinion? How do you see these types of problems, how they show up? And then how do you address them when you aren't part of the problem, but you're part of the results, the trickle-down effect from those that are making the poor decision for the rest of us?
Right. Well, I think it's educating. It's talking to doctors, primary care physicians, explaining to them, talking to patients. And, that's the best you can do. But I can tell you this whole opiate epidemic, so to speak, again, that's also been blown way out of proportion. Most of the opiate epidemic is not doctors prescribing medications. That was a problem and is still a problem to some extent. But most of it is this illicit substances being sold on the street.
Yeah.
But again, everything gets clumped as opiate crisis.
Right.
So that's not really a medical opiate crisis.
Yeah.
It's a total different problem.
Right. Right.
So fentanyl patch is great. It works very well for patients. But now you talk fentanyl and everyone's thinking of the fentanyl where patients are dying on the street. It's not the same thing.
Yeah. Yeah. You talked a lot about some of the innovations. You were saying you now have these records to see if people are doctor shopping and things like that. You go to conferences, you stay pretty current on where the ball is going in pain medicine. What are some of the coolest innovations that you're seeing today that you think will become part of, commonplace in medicine, in pain medicine in like 10 years from now?
I honestly think, like everything else in the world, what is coolest in medicine also is going to be, or is, AI. And I've recently been trying out a scribe model, and it is so, you're going back to the old doctor-patient days where you walk in, talk to the patient, and walk out. And it is so seamless that it is amazing. I think because documentation is such an important part, doctors either, and I've been to a doctor's office where the doctor's sitting in front of the computer, his back to me the whole visit, and I'm a doctor. And I'm like, yeah, I know documentation is important, but then if you don't do that, then you spend hours after the patient encounter, which is not healthy for you too. That's why the whole, doctor burnout is not because doctors don't want to see patients anymore. Doctors love seeing patients. That's why we went into medicine.
Yep.
But doctors don't want to do administrative stuff. They don't want to be doing, hours on the computer. So I think this is going to really be a game changer. I think, AI is going to really, and scribes, and that's really going to make doctors back to taking care of patients and not worrying about documentation.
Have you seen, again, you said you've personally used it. Have you had any other physicians in your practice start to use it? And if so, what kind of trickle-down effects have you seen from them? Have you heard similar reports of again, striking that balance between getting your documentation done and being present during patient?
So we were trying it out. So 3 of the doctors in our practice did it.
Okay.
And we all loved it. It just is, like I said, it's a game changer and it's a no-brainer. It just is I think it's one of the coolest things that is definitely going to be there for the next 5-10 years. That's going to change the way doctors practice medicine. Some doctors are concerned. They say that, well, if everything's being recorded, what happens in a lawsuit, right?
Sure.
But if you're doing the right thing, and if you're in a lawsuit, most of the times, well, I won't say most of the times you're wrong, but if in a lawsuit something happened that you didn't do properly, whether it's going to come out anyway in the thing, right? So I think that's not a valid concern, but some doctors, that's what they're concerned about as well.
Well, I practiced a little bit, again, physical therapy, but saw a lot of post-operative patients and then a lot of chronic pain as well. My dad currently has a spinal cord stimulator actually right now. I know that's something that you have done a lot of. Would be curious to know, maybe the audience doesn't know a lot about what a spinal cord stimulator is. Would love to hear a little bit more from you about that, and then how you've been able to use it in your practice and some of the results you've seen.
So I actually got very interested in this when I was doing my training. I trained at Hopkins, and the surgeon there did the most spinal cord stimulation in the world. He was really, and people traveled from all over the world to do for him. So that's when I really got excited about it because, like you said, it's for patients who have had, or it used to be for patients who had surgery and were not doing better. There was nothing else really to do for them. So that's how this whole thing started. That was the only indication initially. But the technology has come a long way. The first stimulator was put in 1967. So that's how old it is. But when I was at Hopkins, we used to have one electrode, which was 4 contacts. That's it. And I remember a patient would get admitted on Monday. And Monday to Thursday for 3 days, the nurse practitioner would go over thousands and thousands of combinations, plus, minus, plus. Now we went from 4 electrodes to 8 electrodes to 16 electrodes. And you put 2 of those 60, that's 32 electrodes. You can spend a year trying to figure out. So now they've got really smart computer algorithms. So it's like instantly they try out so many different, combinations, see what works. They also newer stimulators now where you don't even feel the stimulation, but it's just, that this is the right place to put it for this problem. So it's come a long way. And now we use it for, there's also peripheral stimulation. So you use it for shoulder pain, knee pain, hip pain. So the indications have gone up for, occipital neuralgia. So it is for a lot more conditions and it works really well. So patients who have had, let's say they've had a knee replacement, right? Still in pain. What are you going to do for them? There's nothing else to be done structurally.
Yeah.
So the spinal cord stimulation you put in works great. So I think it is a great, great technology, but very underutilized.
If you look at the tooling that your practices use, I'm talking tooling that the clinicians use, whether it's medical or technological. I'm talking back office. I'm talking front office. What do you think are the experiences that your businesses give patients that is unique to your businesses? Meaning, what do you guys think you do 1% at versus all the other pain management clinics?
I would say, again, coming back to what I said initially, just taking great care of patients. There's nothing else that works. Most of your patients are going to come back with their father, their mother, their spouse, their kids, and that only comes from great patient experiences. So I think I work hard to make every employee of mine, right from the person who handles the telephone to the new patient department, front desk, guys, you have to understand, the reason we are here is to take care of patients. And, and sometimes patients can be very unreasonable and nasty. And I just tell my front desk, listen, you have to take care of them for 5 minutes. Put on your best.
Yeah.
Right? You're not their spouse. You don't live with them. They come to you because and a lot of patients are really nasty when they come to you. And within a few months, they're the nicest patients because they're in pain.
They're in pain.
Just imagine if you had a headache and you're like a day and you're just in bed, what if you have a headache every day of your life for 5 years?
Yeah.
You're going to be miserable, right? You can't come in smiling. So you have to understand. I think that's what I would say is, again, I can say talk a lot of other things that we do well, but I think that's the number one thing, is just taking great care of patients.
And if you could wave a magic wand, or if your staff could wave a magic wand, what would be the one thing that they would change?
Much more pay.
Fair.
That's becoming, I'll tell you, it's interesting, again, as an owner.
Yeah.
Medicine is probably the only business in the world where your reimbursement keeps decreasing every year. I haven't heard Medicare ever say, we're going to give you more money this year. But costs keep going up. Staffing costs, everything keeps going up. So it's just difficult to navigate sometimes. That's why I think small practices are dead. If you look at the statistics right now, it's either you're a hospital employee or you're a big VC firm. And that's why we are in the process of now forming a big group. We're getting 18 practices together, and I really believe in doctors for doctors. And I believe we want to do something where we kind of recreate private practice, but on a big scale. So every doctor practices and does what they love doing. Every doctor comes in, he owns his business, he takes good care of patients, but he doesn't have to do the things that they hate doing, right? Again, the billing, the regulatory stuff, so all the marketing, all the stuff that they hate doing, business people take care of. And much as doctors will say, oh, these business people, but that's what they're good at. I'm a pain management doctor. I take care of pain. But if someone in my family has chest pain, I'm not taking care of it. I'm sending them to a cardiologist because they know it best. So the business people handle the back office best. So why not leave it to them?
Yeah, I think it's so true because, back in the day, it really felt like private practices would give you really great care because they knew you and they knew your family. And then, they don't see so many patients. So they actually remember you when you come to the next visit. And it's sort of tough because now those same private practices are the ones that are getting squeezed and as a result need to see more patients. And then the entire essence of the private practice sort of goes away. You're seeing massive numbers of patients. It's like they don't remember you anymore.
Right.
It's a tough problem.
So it's a sad thing because, when I finished my fellowship, the first thing I did, I was part of a big group. Then I went off on my own in Manhattan, which at that time people said, you're nuts. Like there are all these big health systems and there was no private practice. I started it and I, fortunately, I did well. And I used to, any young doctor coming to me, I would say, go on your own. Yeah. Just go on your own. In the past 5 years, I've never told any doctor to do that because first of all, health, you can't even get into health plans. And then with all this cost of, your EMR and compliance and all that kind of stuff, it's just not, the doctors can't make a living. So they have to resort to becoming employees. And if you look at the trend, if you look at the numbers, it's scary. 10 years back, it used to be the amount of doctors in private practice to now, it's shrinking to such a small amount.
Right.
So, that's why I think we have to be big groups, but you have to do it right.
Right.
You have to do it so that the doctors feel empowered and they don't come in again. If you just have these big groups and doctors are just employees, they'll come in and, go through the day and go out, and then it's not great for patient care.
Yeah.
So I think that's what's important.
We talked a little bit before our discussion today. You mentioned that your family has a lot of physicians in it. And so with the changes in the medical field as a whole, like you just described, do you have these conversations with them? I mean, do you guys talk about this at the dinner table? The landscape of medicine, the payers, pinching us down more. Like, what are those conversations like with, maybe even share with the audience, like how many physicians are in the family and how these conversations go?
Well, absolutely.
More than 3.
I've got 2 daughters who are doctors and both their husbands are doctors. And then I have a son who has decided that no medicine for me. So he's doing investment banking, and I think he's the smartest among all of us. But yeah, we have this conversation, and I used to have these conversations even before when they wanted to do medicine. The one thing I explained to them is, if you're doing medicine, it's one of the best fields in the world, I think. And if I had to do it all over again, I would go into medicine again. But you got to go into medicine for the right reasons. You can't go because you feel, you're going to make a lot of money. And, it's a hard field. You spend lots of years, and after that, with the environment we are in today, if you don't love what you do, don't do it. My son-in-law is actually done MD, PhD. So he's taken the real long route, right? So it's funny. He was telling me just 2 weeks back, he says, Dad, one of my friends who went into, he started his own hedge fund, like same college buddies. He said, he told me in 2 years he's retiring. He says, I haven't even finished residency. I haven't even made my first dollar and my friend's retiring. But that's the reality. So people have to understand that, people just look at doctors and don't understand. It's a long process, years of hard work. And the end of it, when you come, if you are unhappy, that's sad, right? Why have we gone through all this if you're not going to be happy at work? So
when you touched on automation technology, AI is the big buzzword these days. So given this landscape, right, and you described it well, and that you've talked to people now, like again, you'd say you'd go to medicine now again because you love it. But to those who don't, you would definitely not recommend it because of these challenges. So how do you see AI technology automation influencing the challenges that you just outlined? Do you feel like there's a way to recommend to a young person considering going into the field of medicine right now, right, to give them a strong recommendation to do so because of some of these tools that are available now?
I don't know if I would say that, because who knows what's going to happen. Like I said, by the time they do med school and residency and this thing, it'll be 10 years later, maybe we'll be living on the moon. Who knows, right? I mean, it's amazing how fast this whole world is changing, right? With AI, my son, yesterday, he is like going home in the Uber and he's doing investment banking and he's thinking of changing, what he wants his career to be. And he just, Chat GPT says, I'm doing this. This is my personality. He's a people's person. And he just gave a whole thing on what it is. And the advice that came back to him, I read it. I was like, geez, this is like someone who's been a seasoned person in a private equity firm for 30 years. That's the kind of advice they would give. So it's amazing how this whole thing is going. So I think it's going to be a game changer right now. But as far as young people coming into medicine, I would still give the same advice like I said before. Like I told my kids, go into it for the right reason. You got to love seeing patients and taking care of them. That's the bottom line.
I have another question. I'm sorry, that made me think of one more question, but I love that you're so focused on quality care, right? That's the type of physician I would want to see. That's the type of physician I want my family to see. Any story, a long career, amazing accomplishments that we read about at the beginning. Any stories about patient outcomes that maybe stand out that you'd like to share? Some type of a impactful experience you've had with a positive outcome that maybe resonates a little bit more.
I don't know if I have a specific example, but I can just, over the years, there's so many patients who I've taken care of for years and years. And it's very gratifying to see how they do. And to be honest, when I did anesthesia residency, pain management kind of wasn't a thing, So in my final year of anesthesia, I spent 1 month in the pain clinic. And it was an eye-opening experience for me. It's like these patients who come in for like 10 years, they're suffering, and you do one injection, they do great. And I'm not saying that's the reality of pain management for all patients, don't get me wrong. And I always joke with my patients. I say, you have to understand there's a reason why we are called pain management. We manage your pain. We may not be able to get rid of your pain. So you set the right expectations. I explain to them chronic pain is like high blood pressure, diabetes, right? Most patients who have high blood pressure on medications for the rest of their life, but their lives are better. You have diabetes and now there's so many good drugs. So pain, again, you have to manage the pain. But I just remember countless patients who've done so well. And I love the field. I was very fortunate when I started, the field hadn't even it's just starting off. They were but it's come a long way. Like I can tell you, when I finished my fellowship and I would go out to doctors and introduce myself, to say I'm new in the community and I do pain management. What's that? Like most doctors didn't know what pain management is. And now there's nobody who doesn't know what pain management is. So the field has come a long, long way, and it's much needed. I think for patients with back pain and neck pain, I think the way our healthcare system is, the primary care will send them to the surgeon first. And the surgeon has only two decision making in his mind: operate or not operate, right? Pain management comes in much before surgery. There's so many tools we have to make patients better. So at least in our community, almost all the doctors will send to us pain management first. And that's what's best for the patient. So if we see the patient, we can get them better, fine. If we cannot get them better and they need surgery, then we send them to the surgeon. And actually most good surgeons, unless you have an emergency, will not operate on a patient unless they make them try pain management first. So why delay the whole process, right? Yeah. They go to the surgeon first, then they come to you, so I think, that's why pain management, I think, is getting more and more doctors understand that. So I think that's good for the specialty, good for the patients.
Yeah.
I think that was great. We are very grateful for the time you've spent.
Thank you. Been my pleasure.
Yeah, this was awesome. Thank you.